We're going to talk about type 2 MI, or demand-related myocardial infarction. A lot of people know about type 1 MI, which is the acute coronary syndrome. That's what people think about as the heart attack, clenching their chest. And we know that if someone has a heart attack or type 1 MI, there's this rush, time-dependent treatment and evaluation that gets done right away. However, type 2 MI, which is probably just as frequent as type 1 MI, it doesn't really garner the same amount of attention that it probably needs. There's some evidence, retrospective data to date have suggested that we should pay more attention, but there's really no definitive evidence by prospective study. Our study was one of two prospective studies available now, and it's contemporary. So using the third myocardial universal definition of MI, we defined type 2 MI in patients who had baseline coronary angiography. So we had, coronary artery disease. That's one big question about whether or not people having coronary artery disease that's obstructive or severe enough, is that really causing type 2 MI, or can you have type 2 MI without any coronary artery disease? And so this was a very unique population that we were able to look at the frequency and characterization and prognosis, more importantly, of type 2 MI. So when we looked at it, it was much more frequent than we would have thought. Of the 1251 patients in the study, 152 patients had type 2 MI after they were enrolled in the study, and that's almost over 12%. So it's frequent. We followed them subsequently after they had type 2 MI to find out if this means anything. We looked at event rates of adverse cardiovascular events. And when we looked at it, compared to people without type 2 MI, people with type 2 MI had about 100 event rate per 100% years, compared to about 17.6 event rate per 100% years in people without. So over 5, 6, 7, 8 fold of risk increase in the risk of having adverse events that are major. I'm talking about heart attacks, deaths, arrhythmias that are significant enough to warrant emergent evaluation and treatment, stroke, things that are pretty serious. Symptoms can be the same. These are people who come with very sick acute situation. Maybe they're hypotensive or their blood pressure is low because of sepsis or because of fast heartbeats, because of something else that's going on, but they're having signs and symptoms of heart attack, not because they have a blockage like acute thrombosis, but rather because there's more demand on the heart than it can provide. Both are pretty common, and my guess is that we use the conventional method and kind of the standard of care definition of myocardial infarction, but we know that the sensitivity of troponin testing, which has become the standard biomarker for MI, is better. It's increasing, and some of the research studies, and Europe is already using highly sensitive troponin, and my guess is that if we had moved on to the highly sensitive troponin, we would detect heart attacks even more frequently. I think everybody, I think it's tough, practically speaking, for the emergency doctors to take care of this because they're worried about what is precipitating type 2 MI. However, knowing that we actually compared the risk in type 2 MI versus people who had type 1 MI, and the risk associated with it was just as frequent and just as bad as type 1 MI. So that general practitioners and cardiologists together should really look into it. We found out that really high frequency of patients in this group of people who had type 2 MI, they had coronary artery disease that was significant. About 76% of the patients had at least 30% of blockage in the major coronary artery disease, at least 2 out of the 3 major coronary artery disease. So it's a lot. We don't know. It's one of those things where we're just finding out that it's very frequent and that it's definitely associated with poor prognosis. But we don't have any other information on what's really causing it and what can we do about it, which is why I think this study is important. It brings to light how bad type 2 MIs are and that we need to pay more attention to it, and we need to figure out something. We need to do more studies, we need to evaluate more patients, we probably need the help of more highly sensitive troponins so that we can figure this out. A lot of the studies were retrospective. Most of the studies, except one other, they looked at laboratory findings of positive troponin, and they divided patients into whether they had type 1 MI versus type 2 MI versus, there's 3 and 4 and 5, according to the third definition of universal MI. It was about up to 50% of the MIs were type 2 MI, and then the rest were type 1 and other stuff. I think in the next decade or two, because going back to the other study, there's one other study as part of the TIMI Triton. It's a pretty huge study, and they did a good job. But they actually did the study before the universal definition of MI came out. So we didn't even understand what type 2 MI was back then, and they were just beginning to kind of wrap our minds around it. So that's a little bit outdated cohort as well as the definition that they used. So going forward, we need more prospective studies, such as the study that we have done. I think we're just the beginning of what's to come. They need to be more aware of it. I mean, it's something that impacts people's mortality as well as morbidity, and I'm here to kind of spread the word. We need more research on this topic.